So good evening all. Is my voice clear?
Yeah, good evening. Yes, you are audible, ma'am.
Okay. Okay. So today's topic of Viva is actually energy metabolism and starvation. And while preparing for this topic, what I have realized is we are actually dealing with three topics here. First is metabolism, including carbohydrates, lipids, and proteins. And secondly, the core topic starvation. And thirdly, there are quite a bit applied topics which are related to this. So we will try to touch these topics through this session. Okay. So I think I have two volunteers today. First is Dr. Deepak and second is Dr. Santosh. So he's is he here?
And myself, Dr. Deepak, I am here.
Okay. Okay. So just a minute, I will just check. Okay. So I think we can start, Dr. Deepak. Is it okay for you?
Yeah, sure, ma'am.
Okay. So what is BMR?
BMR is the amount of energy that is liberated when there is metabolism of like protein, carbohydrate in standardized conditions, which include the patient is at comfortable position, the temperature is like environmental temperature, resting temperature,
Okay.
with the overnight fasting of 12 hours, and it is corrected for age, sex, and surface area.
Perfect answer, actually. So it is actually amount of energy a patient consumes per unit time in state of mental and rest in a comfortable environment. Around the temperature is said to be around 26 degrees. It is said to be thermodynamic, thermoneutral temperature actually, and it is corrected for age and surface area. So what is the unit for BMR? How you calculate it? What is the unit for BMR?
So the unit of BMR is like the amount of the one. It is how to explain? It is kilojoules per second. It's like around 4.16 kilojoules per second for each gram of like carbohydrate metabolism.
Okay, but you said it is actually calculated as per surface also.
Yes, corrected for surface area.
So there should be something related to that also. So
Yes,
it is
joules per
kilojoules
per square meter per minute or per hour. Both times and square surface area will have to be considered.
Okay, so it is actually kilojoules per meter square per hour, and if you talk about kilocalories, it is 40 kilocalorie per meter square per hour. Okay. Am I clear?
Yes, ma'am. Yes.
Okay. So what are the factors affecting BMR? You can state as in increase and decrease. What factors increase and what factors decrease?
So the factors which increase the BMR, like basically the factors which affects the BMR are the age, the sex, the temperature.
Yes.
Then the amount, like the type of diet which we are having. The kind of diet which we are having, like carbohydrate, more of carbohydrate diet, more of a fatty diet. So it depends on that. And what is our like resting? We are more of exercising. We are of more at rest. That also determines the BMR. So it's like age. It decreases with the extremes of with the increasing age. It decreases with the increasing age. And more in males as compared to females. Then it is more in cold temperature than the hot temperature. Then the BMR is more for carbohydrate diet as compared to the fatty diet. and then it is more in exercising person than a like a lazy person.
Okay. Okay. So, as you said correctly, the exercise increases hyperthyroidism. I think you missed hyperthyroidism. So, stress, pyrexia, recent meal,
Yes.
and age definitely affects it. So, more in towards neonatal age, and it decreases as the age advances. So, definitely it is going to be less in hypothyroidism and starvation and advancing age. One point I did not understand, Dr. Deepak, that you said the intake which we take, like carbohydrates, lipids, or proteins, that affects BMR. So can you explain that? I did not get that.
The carbohydrates are the readily available source of energy. So if we consume like more of a carbohydrate, they get metabolized easily as compared to the fats. That's what
actually, it's not that way. Carbohydrates affect something else. We'll get back to that point later, but it's not related to this at this moment. Okay. So we'll come to that. Okay.
Sure. Okay.
So I think this is very crucial question. And if you talked about basal metabolic rate, it is also called as basal energy expenditure, BEE. Okay.
Yes.
Are you aware?
Yes, ma'am. Basal energy expenditure. Yes.
So if you are clear about BEE, what is REE? What is resting energy expenditure? Anybody else wishes to answer?
I think it's same or sorry, I don't know about it.
Okay, so as you said that it corrects its lab, the BMR is related to the surface area, to the it is corrected for temperature. So that way you can answer. Resting energy expenditure is taken in a patient when the person is lying in supine position but with eyes open, and it includes the thermogenic effect of food. Like when we were saying BMR, we have asked the person to be fasting for 12 hours.
Yes,
right?
ma'am.
Okay. Yeah. So here we are including the thermogenic effect of food, and it is set. It is by calculating it, it is said to be 10% greater than BEE. Okay.
Okay.
Okay. So there are there are many more EE, like there is sleeping SEE, sleeping energy expenditure, EEE, exercising energy expenditure, but those are not that important. This is very much important, resting energy expenditure. So what is MET?
MET is metabolic equivalent of energy expenditure. So one MET corresponds to 3.5 ml of oxygen per kilogram. 3.5 ml of oxygen per kilogram body weight per minute of consumption.
But
so
what is T? You did not tell me T. MET. Metabolic equivalent of a T for task. Yeah, correct. Okay. Please go ahead.
Metabolic equivalent of a task. So
yes.
It equates to the energy consumption, oxygen consumption in terms of the activities performed. So what MET is equal to resting energy expenditure when the patient is at rest, and like 4 METs is equivalent to climbing 2 flight of stairs.
Yes.
And, like 10 METs is equals to active jogging, and we need at least 4 METs to get the patient is having a cardiac
good cardiac reserve. Yes, you are perfectly right. So metabolic equivalent of task, it is method of expressing energy cost of a particular activity where exercise is graded as multiples of BMR. This is very important. Okay, and rest all things I think you have told perfectly. So it is basically plays crucial role in preoperative anesthetic assessment, as we all know. So there are few terms which I want to just clear because we cannot go in we cannot go details. Yes, there are somebody has raised hand.
Myself, I have confusion, ma'am. Like in some books, it is mentioned that 4 mets is equivalent to 1 flight of stairs, and some books mention it 2 flight of stairs. So like, would be mentioned it's 1 flight of stairs or 2 flight of stairs?
Okay. I think that, does not, basically what we have learned through, our PG curriculum, 4 met is equal to 2 flight of stairs. Because if the person is walking 2 flight of stairs, we consider him, his cardiac reserve to be adequately good.
Okay, ma'am.
Yeah.
Thank you.
So what I wish to say is that, there are a lot of pathways. If you talk of metabolism of each differently, carbohydrate, lipid, and proteins, like citric acid cycle or pentose phosphate pathway, but we cannot remember it at this moment, and those are like not asked in exam. So there are some crucial things that we talk again and again. Okay, so one of it is when we talk of protein metabolism, or especially anabolism, catabolism, we talk of nitrogen balance. Negative nitrogen balance, positive nitrogen balance. So I just want somebody to tell me, what is it, nitrogen balance? How do we want it in our body? What is our goal?
We want like a positive nitrogen balance.
Very nice, correct.
Nitrogen balance basically indicates like a protein reserve. It's because the proteins are the building blocks, and so they denotes how much extra proteins we have in our body, protein reserve. It shows that.
Okay. So how much positive you want?
That I don't know, ma'am.
Okay, so it is just around 4 to 6 grams positive. We want positive. It is our goal in physiology, in normal physiology. Okay. And basically nitrogen, can you see the yellow one downwards? Hello.
Yes, ma'am. Yes, ma'am.
Okay, so there is what you can see, nitrogen balance is equal to nitrogen intake minus nitrogen output. Okay, and that we all know that negative balance is signifies catabolism, and positive balance signifies anabolism.
Yes, ma'am.
Okay, so there are some minute things which we should not pay more attention to, like we in output actually we calculate only urea nitrogen, but they have added some factors, because sometimes there is pus, there are some drains, and there are some things which excretes nitrogen apart from urea. So they have tried to include this also. So basically this is the thing, this is nitrogen balance equation. What I just wish to show is after that there is a graph. Okay, so which shows the relation between nitrogen balance and intake of non-protein calories. Okay, so what I just wish to highlight here is that if we take enough non-protein calories to spare proteins, then we can have good nitrogen balance. Are you just a minute?
Okay, so intake of non-protein calories.
Okay, so if you can just read from the this thing. The first step in achieving a positive nitrogen balance is to provide enough non-protein calories. Non-protein calories as in through carbohydrates and through proteins, to spare proteins. If we do not provide the calories through carbohydrates and lipids, what our body will do is it will lyse the proteins. It will do proteolysis to provide energy, which is not good. So this is just, if you take the constant protein intake, there should be enough non-protein calories to maintain adequately good positive nitrogen balance. That is just the only thing I wish to highlight from this diagram. I also wish to tell something, that this picture I have taken from Paul Marino, ICU book.
Okay.
So you can go through it. If you have some more doubt, you can please go through it. So after this, what is starvation?
So the starvation is basically the complete cessation, or like a fasting state, or if we are not fasting, then our intake is reduced in reduced amount. So for a longer time. So this describes the starvation basically.
Okay, so you mean to say that it is near malnutrition? I mean, nearing.
Malnutrition includes not only the intake. Malnutrition may include that we are taking the food, but the right kind of nourishment we are not getting, like adequate amount of carbohydrates, adequate amount of fats, adequate amount of proteins, adequate amount of vitamins, and adequate amount of minerals. But in starvation, we are not getting any kind of nutrition. Like we are fasting, we are not getting carbohydrates, we are not getting proteins, we are not getting fats. So that is starvation.
Okay, fine. Or it can be severe form of malnutrition.
Pardon me?
May I just elaborate?
Yes, sir.
Yeah, may I just elaborate? It's a state of a body in which there is either total absent or a inadequate nutrition, which leads to use of endogenous sources of the energy sources, endogenous energy sources.
Okay.
So it's the state in which endogenous energy sources are started using. So it's either in the complete absence of nutrition or a inadequate nutrition.
Yes, yes, sir, you are right. Basically, the body has to depend only on endogenous sources because there is nothing provided externally. So body has to depend on endogenous sources, and which are getting depleted as the course progresses. So we are right. Failure to ingest or absorb sufficient dietary calories to sustain normal body function, resulting in behavioral, physical, and metabolic changes. And as sir said, body must survive on endogenous stores. So if we look the progression of starvation by looking towards it in case of duration, in days or months, whatever. So what will be the biochemical changes in initial hours in case of starvation?
Like
somebody has to mute, I think.
Hello.
Yes.
I think there is disturbance from someone else.
Yes, you're right. Is it Meena or I think it was Meena. Okay. So the question was, what will be the biochemical
changes? Yes.
Yeah, biochemical changes immediately in few hours. In few hours.
When we reduce the amount of glucose, that glucose basically what it does, it stimulates the production of insulin. Now this glucose has been decreased, so it inhibits the insulin production and it stimulates the production of glucagon. Now this glucagon causes it tries to maintain the glucose level of the blood through glycogenolysis, gluconeogenesis, and also lipolysis.
Okay.
So the glycogen stores glycogen stores of liver and muscles are utilized. From the liver, it generates glucose 6-phosphate, which goes to the glycolysis and the TCA cycle. Then from the muscle glycogen, lactate is produced, which forms the pyruvate, and that is used for gluconeogenesis.
Okay. So when I ask for initial few hours, there is only actually one answer, that first what triggers is glycogenolysis. In immediate 24 to 48 hours, that is what starts happening. And these changes, they are after say 48 hours, the rest of the thing are whatever you say are totally correct. The gluconeogenesis and lipolysis, they follow it. Am I right?
Yes, ma'am. Yes, ma'am.
Okay. So I just wish to know, what are the tissues in our body which are absolutely dependent on glucose?
Basically, two tissues which are absolutely dependent on glucose are brain and RBCs. The RBCs have no mitochondria, and the brains are also very sensitive, so they are obligatory glucose dependent.
Okay. RBCs and
brain.
Okay. So just a minute. Okay. So brain, RBCs, skin, and renal medulla, they are actually they are obligatory dependent on glucose need. Okay. So as you said, in the initial few hours, biochemical changes in starvation, what we see is you have told actually correctly, glycogenolysis in liver, then it releases glucose, and then it gets followed by lipolysis, of and which leads to liberation of free fatty acids and glycerol. And actually the catecholamines and cortisol, it triggers the beta oxidation of free fatty acids, and which leads to the production of, as you said, high acetyl CoA concentration. So can you just tell me about something about gluconeogenesis?
So gluconeogenesis is basically it's the production of glucose from the non-carbohydrate precursors, which includes the lactate, pyruvate, glycerol, and the amino acids. So in the state of starvation, the muscle glycogen is broken down to lactate, which is converted to pyruvate, and that pyruvate is used for gluconeogenesis. Then the the triacyl glycerides are broken down by the lipases to fatty acids in the glycerol. That glycerol is used for the gluconeogenesis. Then the fatty acids undergoes beta oxidation and produces acetyl coenzyme A. That acetyl coenzyme A will go into the TCA cycle, but as the supply of oxaloacetate is limited, ultimately the TCA cycle will stop, and that acetyl coenzyme A will now go on to produce in the liver ketone bodies, oxaloacetate and beta hydroxybutyrate. And the proteins undergoes transamination and deamination, and then the alanine, which is liberated, goes on to form the gluconeogenesis, glucose.
Okay, yes, everything is correct. I just wish to say that gluconeogenesis, it itself is an energy consuming process actually, and which also leads to formation of energy, but it itself is an energy consuming process.
Yes.
It happens in liver and kidney. I think rest all you have, yes, you have highlighted rest all things. So it also is controlled by glucagon and insulin ratio. That everything is controlled by glucagon and insulin ratio. That is okay. So yes, what is the role of catecholamines and cortisol in starvation?
In starvation, the sympathetic nervous system is stimulated.
Yes.
And the alpha receptors stimulates the production of insulin, and the beta receptors stimulates the production of glucagon hormone. And the cortisol is like anti-insulin hormone. So it cortisol also causes the production of glucose, also stimulates to increase the amount of glucose in the body.
Okay, so it ultimately leads to lipolysis. The catecholamines and cortisol triggers lipolysis so it leads to formation of free fatty acids and glycerols. So as we all know, glycerol is one thing, it's a substrate in gluconeogenesis, as you just told. So it ultimately leads to ketone formation. I think 2 participants have raised hands. Can they unmute themselves, or how is it? Dr. Deepak?
Sorry, ma'am, I forgot to lower my
Hello.
hands.
Yes. Dr. Adri?
Yes. Yes, ma'am.
Yes.
I think it is alpha receptors stimulate alpha receptor decrease the secretion of insulin and glucagon both, and beta receptor increase the insulin and glucagon both.
Okay. Anything else? Till now, it is you are clear till now.
Can she repeat what she said?
Dr. Adri? Dr. Adri, you wish to say?
Yes.
Okay,
Yes.
Yeah. Please repeat. Please repeat, Dr. Adri. Yeah, please repeat.
Hear me? Hello?
Yes, we can hear you.
Hello.
We can hear you.
Hello.
Okay, we'll move ahead actually, and we'll get back to this. Dr. Adri will move ahead and we'll get back to this later.
She is not audible clearly, ma'am. Yeah, maybe come back to her later.
Yeah, please. Okay.
Yes.
what happens in starvation in later part next few weeks, Dr. Adri?
In next few weeks, as I told, that the production as the oxaloacetate amount is limited, now the acyl coenzyme A will go on to produce the ketone bodies in the liver, and now the brain will adapt to utilize the ketone bodies as the energy source.
Yes.
Heart will also adapt to utilize the ketone bodies as an energy source, but this is not an efficient source of energy.
Okay. So basically next few weeks muscles also get compromised and they undergo proteolysis to amino acids. Then they go to liver, kidneys for gluconeogenesis. And as muscle starts breaking down, it results in negative nitrogen balance. Okay.
Yeah, muscle wasting.
Yeah. So when tissues adapt to metabolize ketone bodies, gluconeogenesis decreases, and in all this process, basal metabolic rate decreases. So what is adaptation to starvation? What is body's mechanism to adaptation? Just brisk points.
So the body's adaptation to the starvation is like initial weeks. It adapts, like, first of all, physiological behavioral adaptations. So behavioral adaptations include the body goes into the resting stage and the activities is diminished. Then the metabolic adaptations includes the stimulation of glucagon hormone, stimulation of sympathetic nervous system, and stimulation of cortisol hormones, which aims to increase the glucose level, blood glucose level. To glycogenolysis, gluconeogenesis, and the lipolysis is also stimulated later on, which causes the glycerol and the gluconeogenesis, and the free fatty acids, which forms initially tries to generate ATP through the TCA cycle, but later on it causes ketone body production. Then later on, when the fat stores are depleted, the muscles come into play, and the muscles breakdown starts to consume the protein as a source of energy, and this causes muscle wasting, and the patient's energy expenditure is like completely
I just wish to say that in adaptation, actually whatever is happening now gets reduced when body adapts to starvation after many days. So it reduces the rate of gluconeogenesis, reduces the rate of muscle breakdown, reduces resting energy expenditure. There is less negative nitrogen balance, and even brain now adapts to use ketones for some of its energy need. So this is actually adaptation. So what is the terminal course of starvation? If the patient dies, what is the terminal course of starvation?
So now, as the skeletal muscle starts to break down, and there is diminished energy expenditure, and the patient goes into complete there's no movement, then the tendency or the able to cough out the secretions, pulmonary secretions, are reduced, and those build-up secretions will ultimately cause pneumonia, and the patient ultimately dies of respiratory failure.
Yes. So there is weight loss due to fat and muscle loss, weakness and fatigue due to proteolysis. Weakness includes major, respiratory muscles, and then the gram-negative bacteria, they adhere to the mucosa and they cannot cough out. So it leads to ultimately pneumonia is the main culprit, which leads to death, as said. So if we have a person with starvation, what will be the patient's, what are the markers of patient's nutritional status? Just if you know, otherwise we will just
markers of patient's nutritional status. We can have an idea through the history of the patient, like what is the diet of the patient. Yes. Then we can how active the patient is. Then we can have an idea through the clinical examination.
So history examination. Correct.
Yeah, history.
Yes. Nutritional history.
Anthropology. Pardon, ma'am?
Additionally, a specific nutritional history.
Specific nutritional history.
Okay.
Then we can have some anthropometric measurements, which includes the skin fold thickness over the triceps area. Then we can calculate the BMI, body mass index, or the quality index. It indicates the body's nutritional status. Then we can have some
Yes.
biochemical markers, which includes the proteins like albumin, transferrin, pre-albumin. But the albumin is not a true marker. It sometimes reduces in the septic stages, so it does not indicate the true state of the patient's nutritional state.
Okay. So this was, excellent answer. Actually, this was a kind of tricky question. And I'm really very nice answer. So yes, there are traditional measures like triceps skin fold thickness, hand grip test, albumin, transferrin, total iron binding capacity, lymphocyte counts. But majorly we don't do all these things. Majorly what we depend on is history, physical factors, and nutritional history. Okay. Just to highlight, I just wish to highlight this slide here with only one thing. Albumin half-life is 20 days, transferrin half-life is 10 days, and pre-albumin half-life is 2 to 3 days. Only these three things I want all of you to remember from this slide. Am I clear?
Yes, ma'am.
Okay.
The significance is like of these half-life, it's indicate like the pre-albumin indicates the immediate precursor, and the albumin is a longer time, long-term precursor.
That's the only thing. Yeah, that's the only thing, duration-wise. Otherwise, they are not much used. The markers for starvation, they are not much used. But just to highlight the half-life in comparison.
Okay.
Yes.
Thank you.
Yes. So, if we wish to support the person nutrition-wise, what would be the routes to support the person in starvation?
So through we should not increase the patient's nutrition as such. We should go on a stepwise manner, calculating the nutritional needs and meeting the needs through adequate carbohydrates, fats, and the proteins. So
I just wish to know the routes.
Yeah, routes include the per-oral route and the intravenous route.
Anybody else?
Or through we can nasogastric tube also we can use. Nasogastric tube.
I think nobody else is wishing to answer. Okay. So I think we should say enteral and parenteral. We should say like that.
Okay.
Yeah. So, and then you can classify like this. Okay. This is a different slide. Okay. So here what I've tried to say from this slide is how to decide the routes for nutritional support. Okay. This slide actually shows. And there are some points like muscle weakness. So what I wish to just say is if the patient has muscle weakness, then which route we should not directly send that person to parenteral route, or if there is confusion, then we should solve that rather than deciding aggressively to parenteral. If there is a COPD patient whose PaO2 remains low while eating, he desaturates, so we can just provide nasal oxygenation and he can have oral food. Then it should be decided as per the ease, it should be decided as per the variety, and then as per the availability. So now can you say me what are the enteral routes? You can tell me enteral routes.
So the enteral route includes a per-oral route, then the nasogastric tube, then the feeding jejunostomy. Yes, these are the routes.
Okay, so you are right actually. So nasoenteric routes, they can be nasogastric, nasojejunal tube, nasojejunal, nasogastric tube. Then there can be feeding jejunostomy, there can be PEG, or endoscopic gastrostomy. Okay, so but what are the disadvantages of these nasoenteric tubes?
These nasogastric tube,
so there are actually 2-3 things that they can have. There is gastroparesis. There can be incompetent gastroesophageal junction, so there can be aspiration. Okay, so ideally is it's good if the tube reaches the distal end reaches up to jejunum, NJ, right? but putting NJ tube is difficult. It needs many times it needs endoscopic assistance. So under anesthesia, endoscopic assistance to reach the distal tip exactly up to jejunum. One more thing, what they say is, if the long duration nasoenteric tubes are anticipated, then the tube should be smaller bore, soft, and distal end should be, a thick one, a weighted one, which decreases the trauma. Okay.
Okay.
Yeah. So yes, PEG I already told. So what are the indications for total parenteral routes may have to be considered? What are the conditions?
When the patient's GCS is low,
Yes.
Patient GCS is low. Patient is able to tolerate the oral route. Patient is like having not able to tolerate the oral route in terms of vomiting and diarrhea. Then we
actually not. There are quite severe indications like short bowel syndrome. There is enterocutaneous fistulas, acute radiation enteritis, resistant chylothorax. Then if there is intra-abdominal sepsis and some many more indications. So there are absolute indications that TPN is considered. So TPN routes, can you just, can you or somebody else, can you just say what are the routes, TPN routes, just briefly? What should be preferred?
TPN can be given, as you write, like written the peripheral or central route, but the central route is always preferred because they are hyperosmolar. So the central route is always preferred.
Yeah. Okay. So, for short duration and low osmolar, we can go for peripheral. But if long time is anticipated, then ideal is central route, and that also, subclavian is preferred. In that also, single lumen catheters should be placed, and there should be absolute, aseptic precautions should be taken that way. So if we wish to support now a patient in starvation nutritionally, how should you go ahead with it? With what aim and
sorry, I'm actually
okay.
I didn't that topic.
Okay, so that's okay. So we have to support that, it has to be slow because it is loading metabolic system that has adapted to minimal or no food intake actually. And it should be a balanced intake of carbohydrate, fats, and proteins at intake below REE, resting energy expenditure. And always there should be we should check the signs for fluid overload, glucose, electrolytes. If needed, the use of insulin is recommended, because what happens is there are sudden surges of BSL level goes high when the nutrition supports get started. So rather than cutting down your glucose supplementation, use of insulin is recommended in that case. Then there should not be abrupt discontinuation of continuous feeding. It can lead to hypoglycemia. And last point is very important. The TPN solution should be used in low glucose to lipid ratio. Okay, so glucose to lipid ratio, there are different combinations. Those should be preferred. Nutritional support. In nutritional support, okay, there are few more things like what route should we prefer, and the supply should be tailored as per caloric need. Okay, what should be the protein and amino acids ratio? It depends on degree of stress, nitrogen balance. Then in what should be the lipid carbohydrate ratio? What should be electrolytes? We should continuously check electrolytes, supplement trace elements, vitamins, and all these things basically. Also, if so if we should also consider that what should be the dilution of the supplementation, if whether it should be diluted, it should be concentrated, and whether if we go for enteral feeding, it is calorie dense or it is standard supplementation, that also matters. it should be disease specific. Like, can somebody just tell me that if the patient has some liver failure and we are supplementing him or her, then what things we should consider while providing him the supplement nutritional support? Are there any specific things we should look for? Anybody else?
Yeah, we should look for liver functioning basically.
Yes.
As we are shifting the patient on a feeding, maybe that may be happening after some gap. So starvation, whatever we have discussed, physiological harm and changes are already existing in the body, and if we shift them to the glucose metabolism,
yes,
in that case they can lead to what they call is a refeeding syndrome, which is basically nothing but a hyperphosphatemia, which occurs because of shift to the glucose metabolism, which body is usually used for the lipid metabolism.
Yes.
And that can be catastrophic, or even that can cause a life-threatening situation.
Yes.
Another thing is especially when a patient is on a ventilator, we should be quite specific not to give them more of a carbohydrate, because carbohydrate is the maximum CO2 generating, in the sense respiratory quotient is 1 for a carbohydrate. So in that case also they have a difficulty in weaning.
Okay.
And lead to strain on the respiration. So these 2-3 things should be considered while planning the nutrition, as you had specifically said that we should consider disease specific, then level of serum albumin and all. They should guide us that whether they need a nitrogen positive or nitrogen deficit state.
Yes.
I think all these states should consider, and while selecting the specific eternal supplement.
So just to add, if I talk about liver disease, I just wish to add 2 more things. Like, there is ascites also, where there is a lot of protein loss, so we have to supplement proteins also. But if the same time, if the patient is in hepatic encephalopathy, then we have to and on lactulose. Then there is this balance into all these 2 things. So many times they are supplemented with branch and amino acids, and rest all things, refeeding and everything, that applies for actually every patient who starts with refeeding. So sir has already talked about refeeding, and yes, sir, did you miss something? Just you talked about hypophosphatemia.
Hypokalemia, magnesium, electrolyte disturbance, and they are also equally important to consider.
Yes. So hypophosphatemia, hypokalemia, and hypomagnesemia, they actually classify the refeeding syndrome. Yes, you are right. Okay. So there is something which is called as overfeeding also. Overfeeding is actually exacerbation of refeeding, I would say. So if we overfeed a patient, then if we overfeed with lipids, it can lead to cholestasis, fatty livers. If we overfeed with proteins, it can lead to urea formation. And if the kidneys are not that good to, then it will lead to renal failure. Then it can, if you overfeed with fluid, it can lead to fluid overload. And sir had talked about actually respiratory quotient. If we overfeed with carbohydrates, what will happen? I wish to know what is respiratory quotient.
Respiratory quotient is basically a amount of CO2 produced over the excretion of the CO2. So normally it is a
no, sir, I did not get amount of CO2 produced.
Produced by oxygen consumed.
And per CO2 produced
divided by oxygen consumed.
Divided by oxygen consumed.
Yes, correct. Yes. So how is it related to carbohydrates?
That depends on metabolism. So what source of metabolism? Depending on that, the CO2 is produced more as compared to the oxygen consumed. So maximum it is for a carbohydrate, which is up to 1. 1:1, yeah. And then when at the same time the source of the nutrition is fat, it is lowest 0.7 to 0.8. And when proteins are metabolized, it is 0.8 to 0.9. So average we consider 0.8 for if the nutritional source is a balance between carbohydrate, protein, and fat.
So that means that when we refeed with carbohydrates, the patient has to kind of hyperventilate to
hyperventilate and excrete more CO2 produced in the body. So that can cause problem in even weaning. Especially this problem comes during planning for weaning, and so weaning failure is seen if the patients are fed with the carbohydrate-rich diet.
Yes. The only what adds to scenario is the respiratory muscles are already weak in starvation, so they cannot work hard, and they cannot. It's very difficult to excrete that much CO2. So the what we see is then patients become dyspneic and tachypneic. So this is very interesting point. Actually, I wish to I want all of you to read respiratory quotient table from Miller. There is a last chapter, Miller is volume 2. There is I think second or last chapter, or you can just find to the there is very nice table related to respiratory quotient, and they have given it very nicely. Just go through it. Then we will come to some applied things like anorexia nervosa, weight loss driven psychological disorder. So anybody who just wishes to highlight the characters of it, and if the patient comes for any emergency surgery, then what should we do? Brisk, very interesting topic. Sir, Mahajan sir?
Is basically... Sir, please, you continue, sir.
Yes, Deepak, please go ahead.
Actually, I don't know much. If you know, it will be better, like if you please.
Anorexia, as mentioned, anorexia nervosa is a psychological disorder mainly seen in young females, and their intention is just to keep the weight reduction, and in that they even go to the extent of omitting and throwing out whatever they eat. So obviously such patients, they are poorly nourished and their nutrition status is poor.
Yes.
And so their protein levels are also less in the blood, which is directly going to affect our anesthesia. So anesthesia, we need to plan accordingly. They are same like a hypoproteic patient by any other pathological condition.
Yes.
And they are going to affect the drug metabolism, drug distribution. So we need to plan accordingly all the high protein bounding drugs.
Yes.
We need to give them in a low doses, so that, and even if you are giving them in an infusion form, they can accumulate and they can cause a toxicosis faster. That applies to the local anesthetic like the bupivacaine and most of the drugs what we are using. So from that point of view, our assessment and planning should be there for anesthesia in these patients.
So just system wise, I just wish to go to system wise. So respiratory, there is purging induced metabolic alkalosis, and they compensate it by bradypnea. Then in cardiac, sir already said that they vomit so much, and there is decreased food intake, and then also they vomit. So there is hypotension, there is bradycardia, many electrolyte imbalances, impaired LV contractility. GI also, sir said that repeated vomiting, esophageal stricture, salivary hyperplasia, there can be Mallory Weiss tear, and the significance is the patients are considered to have prolonged gastric emptying. So rapid sequence induction is indicated. One more thing is loss of subcutaneous fat leads to hypothermia. So while positioning, we should protect them from peripheral nerve injuries. Okay. And as sir said, decreased plasma protein concentration can lead to increased unbound concentration of our drugs. So there can be prolonged QT intervals in ECG, AV block, esophagitis, pancreatitis, and they always come for emergency surgery. Elective surgery should be postponed till the status is optimized. But whenever they come for emergency surgery, invasive monitoring would be indicated, as they may have acidosis, hypokalemia, and hypocalcemia, hypomagnesemia, and everything basically. So right. So with this, there this was applied related to starvation. One more is ERAS protocol. So ERAS protocol, how will you relate it to starvation? Is there something in pre-op guideline for ERAS protocol related to starvation?
Yes, for ERAS protocols, it said that we have to feed them. We feed them clear water 2 hours before surgery.
Yes.
So that causes improved gastric motility and improved patient's outcome.
No. Feed them with what?
Clear carbohydrate. Clear carbohydrates.
Yes. Okay. So that it does not, worsen aspiration risk also. And so metabolic consequences of major surgery are actually hyperglycemia, insulin resistance, and protein catabolism. So carbohydrate loading 2 hours preoperatively, it's said to lead to like less insulin resistance and less loss of muscle loss. So which leads to postoperative better outcome. So ERAS protocol is in preoperative, it is related to starvation. Okay. There is one more slide. Okay, so just to highlight, I just wish to highlight ERAS protocol here. Can you just, this is very, very important, ERAS protocol. Preoperatively, we saw, I think, then there is intraoperatively short-acting drugs and analgesics and local anesthetics, epidural use. So I think this you should read and be thorough with it, ERAS protocol. I just wish to add the slide here. Okay, so this is my last slide. Before I end, I wish to just highlight few things that TPN is very, very crucial chapter. Okay, and I wish to read more about it, and I wish to take the lecture about it maybe in next 1 or 2 weeks. But there are some like a few things like what is immunomodulation in TPN, what is usage of glutamine arginine in TPN. So those are very, very important things in ICU IVAs. And don't go much into much detail related to carbohydrate, lipid, and protein pathways. They hardly ask to, it's not possible to draw all these diagrams, but we just have to remember the significant things. What are what is gluconeogenesis, or it is not the reverse of glycolysis, it is the energy consuming process, and few important crux we should know. So this is the last slide. Actually, it's already visible. So insulin and glucagon, they control all the metabolism of all three. So just what is this we should know. Insulin, it is a polypeptide. And can somebody just say the effect of insulin on carbohydrate, protein, and fat?
Insulin is basically a anabolic hormone. On insulin, it promotes it stimulates the production of insulin, and that's how it stimulates the utilization of glucose. It promotes the glucose entry into the skeletal muscle and liver to GLUT4 channels, and it stimulates the utilization of glucose through glycolysis. Then in lipids, it stimulates the promotion of lipogenesis. It promotes the lipogenesis. In proteins, it stimulates protein basically breakdown. Sorry, it decreases the proteolysis and it stimulates the synthesis of proteins.
Yes. So we have to talk everything regarding it. Promotes uptake, storage, and and decreases breakdown of all three, as it is an anabolic hormone. And then you can talk in different ways. Okay. Okay. So this was my last slide actually, and I think next time I will try to take TPN. I also wish to read more about it. And I think any queries we can. Yeah.
One question, like one of the member has said that alpha receptors inhibit both insulin and glucagon, and beta receptors stimulate both. So how is it possible that at the same time
no, it is not like that.
Inhibited and stimulated at the same time? I think in podcast also it mentioned that the alpha stimulate insulin and beta stimulates glucagon. So what is the correct
Okay.
Actually, ma'am, in podcast, it is mentioned that alpha adrenoreceptor stimulation results in inhibition of insulin and glucagon, whereas beta adrenoreceptor stimulation results in stimulation of these two hormones.
No, that is mentioned like it increases the secretion of glucagon. and inhibits the secretion of insulin. Alpha receptors I'm talking about.
Yes.
So alpha receptors, they inhibit the insulin and they secrete the glucagon.
I think I will read and I will then put it. There are 3 opinions and I'm not very sure about it at this moment. So maybe we should read for textbook.
Net result is inhibition of insulin and stimulation of glucagon.
Correct.
In fasting state.
Can you repeat?
Is it possible that
the net result is inhibition of insulin and stimulation of glucagon secretion?
Yes, sounds actually logical. Yes.
Yes, yeah, that's what I'm saying, that alpha stimulates the insulin and inhibits the glucagon, and beta stimulates glucagon and inhibits insulin. That's what I'm saying.
Yes. You agree? Everybody agrees? I will read more about it and actually try to post it.
Sure, ma'am. Sure. Thank you.
Yeah. So I think I will leave the meeting here.
Thank you, ma'am. Thank you for the nice.
Thank you. It was nice. I'm very proud and happy that Madam belongs to Nasik. So I can have a direct guidance from her regarding the EDAIC. That was really nice, ma'am.
Thank you, sir. I'm blessed to be, here.
Few inputs were very nice, which were like nitrogen and all. I think Deepak and everyone, we all will agree that those who are following podcast and all, you had given a little different horizon to all these things. We can think from a different angle.
For my EDAIC, I had not just read podcast. It is advisable to read whatever you have read earlier. That's what I believe. So the tables from Miller, the tables from crucial diagrams from the Paul Marino ICU book, and what these are the things which we read in our residency. So they are easy to reproduce in front of whatever question, maybe they are easy to reproduce. So the few things I want to recommend you to read. Just a minute, I will tell you the chapter name. So there is a chapter number 95, Nutrition and Metabolic Control, from Miller's 2nd volume. So at least I request all of you to go through the charts. They are very, very important. Okay.
Ma'am, can you say again which chapter?
Nutrition and Metabolic Control. This is the chapter which we did not read in detail in our residency through Miller.
Okay, ma'am.
At least I just wish to want all of you to read the charts.
Okay, charts.
Only 4 or 5 charts. Yes.
Okay. Thank you. Thank you.
Thank you. Yes. Good day.
Thank you.
Thank you. Good day.
Yes. Thank you, sir. Bye.